Cool. Can everybody see my screen and hear me?
Yes.
Fantastic. Okay. Your maternal history tonight. This lady is a Gravida 1 paranaut. She has a medical history of having a myomectomy in 2021 and a varicose vein removal in 2023, and she is a BMI of 21. At 37 weeks, she had an ultrasound scan. Femur length was under the 10th centile, as it was previously as well. And she was sent into triage for fetal tachycardia on the ultrasound, but that was normal in triage. And then overall, she had an estimated fetal weight on the 50th centile, and other parameters were completely normal. Please forgive me if I seem a bit slow this evening. I'm coming down with the flu, and also I've spent the whole day on a CTG training day, so my brain's a little bit boggled. She comes in on the 8th of the month. Sorry, I should have put in, oh, I did. On the 8th of the month, she is 41 weeks and 1 day, and this is the CTG that you come across in triage. So this goes over till the 9th, set 20 past midnight. She's obviously, this is suggested to have been a baseline of 160, whereas her previous CTG was 130 beats per minute. She was admitted to labour ward for CTG observations with a plan to move to Hope ward, which is our antenatal ward, if the CTG normalised. And she did have a VE that found the cervix to be a centimetre dilated.
Is the baby moving?
Yes.
Plus plus.
Plus plus. So what do we think?
Well, the reason that I asked that is because we've had a few cases like this at Kingston where it looks like a really raised baseline, but it turns out just to be loads of fetal movements. But obviously, I don't know if that is the case with this, but I think, yeah, we would do the same thing in terms of continuing the CTG to see if it manifests one way or the other.
Yeah. Yeah, for sure. She's also contracting as well quite well. The baby's moving, which again is a reassuring sign, baby's moving whilst you're having contractions, so you're not feeling the need to conserve energy or anything at this point in time. So yeah, and also when you look at this, it's one of those weird ones where you could say that the baseline is like 180, and then these are decelerations if you look at it from one perspective. You could also say the baseline is 160 with accelerations, but also there's times where the baseline sits at around 140 or looks like it's sat around 140, although it doesn't spend enough time there. And then all of it could be counted as acceleration. So I definitely think the right decision was made to move her to labour ward. And the only way that we're going to be able to figure out whether or not this is a true fetal tachycardia or not, is to keep it on for a bit longer and then kind of give a bit of a sit and wait approach and hope that the CTG resolves and returns to somewhat of a stable baseline. So we'd want to see some cycling just to kind of reassure us that this baby's kind of going through the motions. So she was taken to labour ward. It's now the 9th of the month. And this is your CTG. At 01:15, I don't know what, I think I may have missed out an hour of CTG here, so apologies for that. Sometimes when they're not put on the central monitoring, as soon as they're admitted, there's a bit of a delay in getting the CTGs, and often those little segments go missing. And I couldn't find the paper form of it anyway. At 1:15 in the morning, they started a litre of Hartmann's, and the plan was made to examine her in 4 hours' time. So just as a sort of reminder here, at 00:50, she's 1 centimetre dilated. So let's call it 1 o'clock in the morning. So they want to essentially examine her at 5 a.m. This is your CTG now. And it continues to look like this.
Better.
So, yeah, much better, isn't it? There's a couple of things that I want to highlight here. And this was the same conversation that I had on the day. We've got what we thought was a possible fetal tachycardia, right? Babies don't sleep tachycardic, so we know the baby was active, moving lots and lots, which is fantastic. We obviously have done somewhat of conservative measures in the fact that we've taken her to labour ward to observe the CTG. This woman is a primate. She's had a previous myomectomy, so she's going to possibly need a CTG in labour anyway because that's her risk factor. However, we've brought her to labour ward. The CTG is now completely normalised. What is the need to examine her in 4 hours' time?
Tara, in my opinion, the fact that she came with a tachycardic trace, I want to know, especially with the previous myomectomy. So I have my theories about previous myomectomy as well. So and this is where again the knowledge of the myomectomy, if we knew how was the myomectomy done, and if it was in our hospital, and if there was big myomas. Sometimes I know sometimes we say it hasn't breached the cavity and it is fine, but sometimes it is the muscles are dysfunctional contraction. So I'm not advocating to examining again. I'm not saying so, but if the clinician wants to know more information about whether she was contracting or not, and whether there is a progress or not, or whether there is a kind of an anxiety about her progress in labor at all, and trying to make excuses to section her and finish the story, because a section as well sometimes is difficult to perform in a previous myomectomy. So sometimes there is a hidden agenda that nobody knows the clinician wants to do.
I totally get that. And I know that there's certain things that we're
Cara, you're on mute.
oops. Sorry,
Sarah, we can't hear you. Yeah.
Can you hear me now?
Yes, now, yes.
Yeah.
But the previous time when you were talking about something, after I talked, we didn't hear you.
Apologies, guys. I must have pressed I told you I'm tired. I must have pressed the mute button by accident. My thought process on this, though, is you've got a lady that's she's gone into spontaneous labour. She's 1 centimetre dilated. We've brought her to labour ward to kind of risk assess her in a more high risk setting. We've got her on a monitor. The monitor is now normalised. Now, let's just for 1 second take myomectomy out of the equation. We would, if that was the case for any other patient, we would probably either say, okay, your CTG is normalised, you're still in early labour, we can send you to our antenatal ward for observation and do CTGs regularly and keep an eye on your contractions and make sure that you're well in labour. But for this woman, we are almost like, okay, she's now 1 centimetre. The thought process for me is, okay, we've brought her to labour ward. Now she's not allowed to leave. So what are we going to do? We're going to create this plan of examining her in 4 hours' time. And if she's not made progress, then we're going to interfere, which would be by the means of an ARM, and then will lead to oxytocin, which is actually going to put her at a higher risk because we're introducing an artificial hormone as opposed to just letting her labour progress naturally and responding to her cues if she is in any discomfort, distress, or anything like that.
Yeah,
When
you are
you've got
right.
a beautiful CTG that's completely normal.
Yeah, you are absolutely right. It is here. People are intervening for an anxiety and about her laboring at all, rather than for any clinical reason. There is no scientific or clinical reason here. It's all an anxiety.
Absolutely. And
Yeah.
and as much, we all, human factors are clearly playing a part here. It's 3 o'clock in the morning. There is going to be an element of anxiety in the clinicians that are working alongside her, purely due to the fact that she's had a previous myomectomy. But our own anxieties shouldn't be the reason that we then start medically interfering with something that actually could end up being completely physiological. And if that is the case where you're questioning it or whatnot, then we should maybe ask, get the MDT team together. So call the consultant on call, have a conversation with the midwife in charge and whatnot. Because currently we've got a lady on a CTG that doesn't actually have a clinical indication to be on a CTG. And then we continue, and this is your CTG continued now. We go on like this for the next sort of 3 hours. So she comes in at around 11 o'clock. It's now 5 o'clock in the morning. We did, don't get me wrong, have a fetal tachycardia, which concerned us. We've brought her to labour ward. We've risk assessed her. We've kept her on a monitor despite the fact that CTG is normalised and she's not really contracting. And now we've done an examination, found her to still be 1 centimetre, but she's ARMable. And the plan is now for an epidural and an ARM. Why do we have the need to do that when actually this woman will probably benefit from just going into labour naturally without the use of a synthetic hormone that could actually be an even higher risk of causing a rupture or an abruption?
Excellent point.
Thank you. Anybody else want to add a comment in here at all?
Yeah, why does she need an ARM?
She doesn't. The reason that they want to do an ARM is to then induce her. But actually, she doesn't need an induction.
Yeah, there's no clinical indication for induction.
No.
I don't really understand why she's on a CTG anymore. Because as far as I'm aware, there's no link between a myomectomy and hypoxia. So I agree that the place for her to have her baby is probably labour ward if we're worried about the risk of PPH. But I don't really see why she's on a CTG, or why she needs an ARM.
No.
So yeah, I'm with you.
The thing that very much confuses me is the fact that we talk so much about risk factors, and we talk so much about like physiology, right? But when it comes to things, Mr. Naguib, I know this is where you say things like obstetrics is an art form, and I think I say that about 5 times a day because it's so true. And clinical judgment is going to be different in pretty much anybody that you go and speak to in the entirety of the maternity unit. But we talk so much about risk factors and, oh, what are the risks of this? What are the risks of that? And I think sometimes we forget that when we're interfering, that actually that's adding on more risk factors than we had in the first place. Whereas actually, if we just left women alone quite a lot of the time, then we would probably end up with a lot better outcomes. So anyway, this CTG continues. This woman would like to have an epidural prior to ARM. I should also note that this woman is sorry, this woman is also a GP. So she has, medical knowledge, not specifically obstetric GP or anything like that, because I know they don't do prolonged periods of time on maternity, but she's aware of this. She's aware of, the effects of an ARM and an oxytocin. So she's very well informed. But I think what wasn't discussed with her, this is what I've got from the obstetric plan, was that the plan was made, okay, we'd like to do an ARM and then induce your labour, but the option of actually the sit and wait approach I don't think was discussed. Anyway, she wanted an epidural prior to having an ARM because she knew that she would end up starting Synto, but due to a few emergencies that were ongoing in theatre at the time, the anaesthetist couldn't come and see to her. So we continue. She had some bloods taken. We've got some beautiful cycling here. Our baseline is super steady. We've still got fantastic accelerations, good variability, no decelerations at all. HB is 121, platelets of 154, and white blood cell count of 11.2. She's still reportedly contracting sort of 1, 2, and 10, as per the midwife's documentation, and I think it's pretty accurate with the TOCO in this case. And we just crack on like this for a wee while, to be honest. At 7:10 in the morning, she has a short break from the CTG. I don't know why, because it's not documented, but I would assume a break to go out to the toilet, and then maybe a discussion was had as to, okay, she can come off the CTG prior to her epidural and whatnot, because there's a little gap here. And then at 8:25 in the morning, our lovely day staff have taken over. They're aware of the fact that ward round's going to occur, and so they put this woman back on the CTG. And as you can see, still no real changes. She's still got the Entonox, which she's using for contraction pain. No reports of anything smaller dose-wise like paracetamol or dihydrocodeine. I think, again, this is, we would always offer women the pain relief that they need, but Entonox is normally something we'd give a little bit further down the line once we've kind of exhausted the tablet versions, essentially, just to sort of help women take the edge off of the pain in labour. There's no report, again, guys, of any abdominal palpation with these contractions. So again, I'm going to say this is a key message until I'm completely blue in the face. We need to be recording an abdominal palpation as well as resting tone palpated, and whether or not we're feeling contractions regularly, if we're feeling them for an amount of seconds, if they're mild, moderate, hard on palpation and the like, specifically more so with women that have had previous abdominal surgeries. It's even more important because they are at things like higher risk of rupture or abruption. Here as well. So at 9 o'clock in the morning, the doctors come and do a ward round. And this registrar sits down with this patient and says, okay, you've got two options. We can either do nothing, we can do a sit and wait approach. You can go to our antenatal ward and you can have your labour continued. Or if you want us to, then we can induce you. And this woman was keen for an induction. So the registrar does an examination. The reg finds her to be 1 centimetre dilated and says that she is ARMable. So the plan is made again, continuing the plan from the night shift, is epidural and then an ARM and then eventually Synto. This decision was made at 9 o'clock in the morning. So we continue. I'm not quite sure why there's so much loss of contact on the CTG here. But I'm assuming it's due to the fact that she's having an epidural sited. Again, another key message that I permanently go on about is the fact that we need to be making sure we've got CTG contact whilst an epidural is being sited. This woman has her epidural at 10:03. That is her test dose. And then at 10:16 in the morning, she has an ARM and is found to be 2 centimeters dilated.
What is really sticking out to me in this case, Cara, is or a question I guess I have is, what is the rationale? Because what forms part of your informed decision making, or the discussion that you have with the patient, is the rationale for our intervention. So I would be interested to hear what the rationale is, because true, good informed consent, as we're always taught, is your risk benefits and most importantly the rationale. So I and also what other alternative options do we have? So I just think that it's missing in this scenario, which makes it quite difficult.
Yeah, absolutely. The conversation was had with the woman. Essentially, this induction now is for maternal request. Because the obstetrician on the ward round said, we don't actually need to keep you here. Your baby is absolutely fine. You are well and happy. Obviously, she's been given the Entonox and whatnot. We do obviously have that on our antenatal ward, but it's not as sort of commonly used. But the reason for induction here was pretty much written down as maternal request.
Okay.
And yeah, risks and benefits were discussed. That is something that we obviously take into consideration, but it's not something where we would have anybody come in from triage at 37 weeks and say, I want an induction, if you know what I mean.
Yeah, makes sense.
Cool. So we continue. Again, everything is absolutely normal. Baseline looks like it goes up, but actually sort of returning back to the baseline it was at before, after a period of activity. And then we move to a thrown position. I think I don't know if an FSC was put on or not, or I don't know if this is our central monitoring system that's doing this at the moment, but it's very confusing. It goes from sort of black to blue, and that normally happens when we put on an FSC, but actually we didn't put on an FSC in this case. So I'm not really sure. I'm not really sure why it's changed colour. But again, baseline normal, beautiful normal CTG, non-hypoxic. Which then continues. I'll skim through a few of these. This patient is reporting some sort of breakthrough pain. So at 13:15, an extra epidural bolus was given. I think her contractions were sort of more moderate on palpation at this point as well. We continue. We gave her 4 hours post ARM, and then her post ARM VE was 2 centimeters. Interestingly, something that got brought up in my obstetric CTG study day the other day by one of our new lovely registrars was the fact that there's no actual evidence to suggest that waiting 2 hours post ARM has any sort of effect on cervical change, and therefore it's not sort of routinely recommended that we don't just start Synto straight away. I don't know if anyone's got any opinions on that, but just thought that was quite an interesting thing to know about.
I do. What about of course, what about like positive birth experience, giving the woman a chance to try and see if she gets into labour, and just giving her that opportunity to see if the ARM works?
Oh yeah, for sure.
Because I know I've read that evidence and I agree. I totally agree with what that registrar is saying. But there's a lot of weight to be said in the woman feeling like she's had the opportunity to try, and then at least there's no questions left for her that she's like, what if, or felt like she wasn't giving a chance to let her body do something. I don't know.
But then also taking from that as well, all about our informed consent, as we were saying before, realistically or technically speaking, then every time we perform an ARM or consent a woman for an ARM with the then means to start Synto. So for example, in a case like this, if it's, you know, a case of, okay, we've got a woman that's 6 centimeters dilated and then 4 hours later she's still 6, but there's a massive bulging bag of membranes in front of the baby's head, and that's the reason we do an ARM. In that case, we're going to expect a woman to sort of progress, or we're going to hope at least anyway that she progresses. So in this case, if we're using an ARM as a method of induction, then what we should be discussing with women to make sure she has informed consent and can make informed choice is we should be discussing the fact that actually post ARM, there is no evidence to suggest there's any cervical changes within 2 hours. So you're more than welcome to have the 2 hours, but just so you know, there's not actually any evidence to suggest that you're going to progress within that 2 hours. And so they should have that information in order for them to make informed choice. No?
Yeah, no, they should. Definitely. Definitely. But you never know, she might, because she was contracting before. I don't know.
Yeah.
I'm all flowers and roses and positivity. So
No, I definitely, well, I try to be a lot more sort of flowers and roses, but yeah, if we're talking about informed choice and informed consent for anything, we should be actually giving all the facts out. Whereas it's not something that, you know, I take part in ward rounds or provide care for women on a regular basis. It's not something that before the other day I realized we're probably not doing to perfection, because we should be discussing those things. Mr. Naguib, do you have an opinion on that at all?
As you said, I completely agree. There is no evidence behind waiting 2 hours or 4 hours or whatever hours. My views is it applies to case by case. So somebody that I wanted to get on with her delivery, not only because I want to get on with her, because the labor ward in total, I have a ship. The ship is full of passengers, and I want to reach safety. Contrary to a single doctor or a single midwife taking care of a single woman. As we do our last exit exam in the Royal College of Obstetrician, they like us to demonstrate helicopter view of the unit, of the labor ward. So it is not always, as I say again, related to the patient that we are talking about. And as all of us, I don't know, all of us or some of us would have written statements in bad cases. Personally, I did. I have to demonstrate why I delayed the management, for example, in room 5 in order to manage room 6, whatever it is. So we cannot think about XYZ in isolation. And if we want to, we need to have, for example, midwife for every patient, one-to-one care that we always talk about. But we need also to have about 4 or 5 obstetrician on the shift. If we achieve that, then we can talk about waiting for this lady and waiting for this lady and waiting for this lady. So it is not only science related to ARM and Synto, it is a bigger holistic approach to this woman and to other passengers on the ship of that day. And unfortunately, whatever we talk about and whatever we want to say about one patient management, you cannot manage one patient in isolation of the other 11 rooms in our labor ward. So yes, I agree. In an ideal world where I have one patient in my care, where I am taking care of only one patient, ARM and wait. Yes, why not? If she doesn't contract in 2 hours, in 4 hours, put Cinto. Yes, we can wait. Absolutely, yes. So, yes, there is no science behind starting 2 and 4 hours. Definitely.
Perfect. Thank you, Mr. Naguib. So, the midwife that caring for this woman then goes on her break, and Cinto is not started in her break. So we've now had a woman that was ARM'd. Forgive me if you're going backwards. ARM'd at 10:15 in the morning. She's at 2:15. She's made no progress, and then we don't start Cinto. I don't know what happened quite there, but it looks like a rather large contraction. But we don't start Cinto until after this midwife is back from her break relief. So far, this is the only difference in CTG that we've seen, and it's possibly due to a large contraction. However, CTG beforehand and afterhand completely normal. Still got presence of accelerations, and I think the time in the middle sort of segment is actually maternal pulse at the time. Apologies, I haven't put any obs on here. I absolutely meant to, but I did look through them. They are all sort of sat around the normal ranges and whatnot. No temperatures throughout labour. Blood pressures were all within range, and maternal pulse was sat between 80 to 90. Cinto is then started at 15:50 on 3 mils per hour, which then continues. Which then continues. We've got a little baroreceptor deceleration there. With that contraction, Cinto's then increased to 6 mils an hour. Still got nice, normal, stable baseline, good variability. Still got accelerations present. Non-hypoxic CTG. Now this is where this CTG starts to get a bit interesting. So at 7:09 in the morning, so this CT in the morning, in the evening, 17:05 in the afternoon, sorry, this baby starts to decelerate, which looks like it recovers or attempts to recover within around 3 minutes. Conservative measures were instated. So at 17:09, this woman was moved to left lateral. And then at 17:10, so pretty much smack bang in the middle of that deceleration, she's moved to right lateral and baby recovers in a right lateral position. And it comes back up beautifully to the baseline. This woman became incredibly anxious at this point, and said, please do something, because she was very concerned for the well-being of her baby. So the obstetric registrar comes in at this point, and examines her. She actually comes in earlier than that. She comes in around 17:15, and then does an examination and finds this woman to be 4 centimeters dilated. So absolutely fantastic. This woman has now progressed. Our baseline has risen from sort of 130 to 140, but still remains normal variability in between, and still got lots of reassuring signs at this point. Cinto was stopped as well. I should have mentioned that. It's only on 6 mils an hour. The baby clearly didn't like it. And so the Cinto was turned off in the middle of the sort of prolonged deceleration here. And yeah, conservative measures all well. So at 17:35, the parents are actually requesting a cesarean section due to maternal anxiety. Despite the fact that the baby has recovered well. This is when the patient reminded everybody that she was a GP, so she had ongoing concerns, and she didn't want basically what had happened previously to happen again, whereby we had that large deceleration. So, non-hypoxic trace, right? 18:12, transferred to theatre. 1816, epidural top-up. 1821, decel is started in theatre. 1827, knife to uterus. 1838, knife to skin. Knife to skin at 1827, knife to uterus at 1838. At 1836, there was a request for consultant assistance, and then baby was delivered 3 minutes after that. That should say 28, apologies. Sorry. There was a total of 11 minutes between knife to uterus and delivery.
Sorry, Cara, can I just ask why there was a request for consultant assistance?
Difficult delivery. And they thought they may, I'm pretty sure the reason was they might have to extend incision, or they just couldn't get the baby out.
Great, thank you.
Yeah, they're always always call for a consultant assistance if you're struggling as a registrar. I think the consultant arrived just after this delivery. What do we think the outcome was for this baby? Anybody want to guess?
7.01 acute hypoxia.
Yeah, was somebody else gonna say something? No. So if you think about it in terms of maths, which is a great subject, acute hypoxia, the pH of the baby drops 0.01 every single minute. So in a period of 20 minutes, you can go from having a healthy baby of 7.2 to a baby with a gas of 7.0. This baby so far possibly before the acute hypoxia, probably sitting in the sort of 7.2s. Just maybe it's deteriorated a tiny bit just due to that deceleration. However, recovered beautifully, back to baseline, back to where that gas exchange takes place, and back to where exactly we would want it to be. So if you think healthy baby beforehand, a period of time of 20 minutes is quite a significant amount of time to be in an acute hypoxia. Sadly, this baby had very, very poor gases. APGARs of 1, 7, and 9, pH arterially of 6.87, a base excess of -15, and a lactate of 11.3. These are definitely different gases. This baby required 2 sets of inflation breaths, and it recovered very well. It was admitted when it was self-ventilating in air. And thankfully the gas when it was repeated after an hour was 7.2, and this baby had some CFM monitoring as well, which had 6 hours of lovely monitoring. These gases were taken within the sort of half an hour time frame of delivery as well. So it surprised me it's very much surprised me that they were that low. But yeah, baby has since made a full recovery. There's no CFM concerns, and the repeat gases afterwards were completely normal. Does anybody have any questions?
It's more of a remark, really, or like this what I was saying in the beginning. Whenever any obstetrician sees previous myomectomy in the horizon of labor, it is in the head of most obstetrician, it is going to be a difficult delivery. It's going to be a difficult cesarean. It is going to be full of adhesions. Entry will not be the most straightforward. If this myomas were anterior, sometimes the uterus gets completely plastered to the rectus sheath. If it is on the side, sometimes it is impossible even to access. Sometimes the bowel is stuck with the bladder in front of where you want to cut from the point of view uterus. So that is exactly what was happening from the beginning. And that's why I was trying to dig into the brain of the people around. They wanted to make excuse to early delivery rather than, or elective delivery rather than an emergency delivery. So this is number one. Number two, in between the lines, it was obvious at the end when Cara mentioned it. Being a GP, being a colleague doctor, colleague midwife in labor, puts extra pressure on any um, professional that these people are, as we called it in the past, or we used to call it a recommendoma syndrome, where something will happen. Many times when I deliver colleagues, I try to exclude from my head they are midwives or colleague doctors or whatever. But sometimes you cannot do that. So this is another factor in this situation. So it is a huge and fantastic CTG lesson today to what is a human factor, or the surrounding that can influence all decisions that we do.
Thank you, Mr. Naguib. Yeah, absolutely. Human factors, I think we really, really underestimate how much of a big part they play in everything to do with clinical practice. Perfect. Well, thank you everybody for this evening.
Thanks, Cara.
You're welcome. See you next week, everybody.
Thank you very much, Cara. Thank you.